Hello everyone, my name is Jen Nolan and I'd like to welcome you to the 7th webinar in Move, Muscle, Bone and Joint Health's 2017 Musculoskeletal Health webinar series. Tonight's webinar is on the topic of the role of footwear in the self-management of knee osteoarthritis. We have some great webinars in the second half year and I'd particularly like to draw your attention to the 2 free webinars we have available in October and November thanks to funding from AbbVie Proprietary Limited. Please also remember that the recordings of previous webinars are available for purchase at any time. Our presenter for this evening is Professor Rana Hinman. Rana is a physiotherapist and an Australian Research Council Fellow, Future Fellow at the Centre for Health, Exercise and Sports Medicine within the Department of Physiotherapy at the University of Melbourne. Her area of research is knee osteoarthritis, in particular, the development and evaluation of non-surgical and non-drug treatments for this condition, and conduct of clinical trials to test the effects of new treatments. Exercise and footwear interventions are particular areas of expertise and a major focus of her research. She has a large body of peer-reviewed papers and has received over $10 million of research funding for her work, including both NHMRC and ARC support. Without further ado, I'll hand proceedings over to Rana. Thanks very much, Rana.
Thanks, Jen. Thanks for that introduction, and thanks everybody for joining us tonight, and certainly thank you to Move for the opportunity to speak to everybody this evening. As Jen said, I'm going to be talking this evening on the role of footwear or shoes in the self-management of knee osteoarthritis, and this has been a particular research focus of our research group here at Melbourne Uni for quite a number of years, and actually sort of stemmed off from work we initially started doing around looking at inserted insoles into footwear, and from we moved sort of on from insoles to looking at the role of shoes and footwear itself. And so I'm going to be speaking to you tonight about some of our recent research, but to give you a bit of an idea about what I'm hoping to cover this evening, I'm going to talk a little bit about the biomechanical rationale for why footwear may have benefits at the knee joint for people with osteoarthritis, and then focus on what the evidence, what the current research evidence tells us at the moment, and so what we know from there. And then to sort of the last section of my talk is to really focus on what should we be telling our patients or advising as clinicians when patients ask us what types of footwear they should be wearing, or as they frequently do. And in this section, I'll particularly be also reviewing what the current clinical guideline recommendations are regarding footwear in the management of knee osteoarthritis. Just before I start speaking, just by way of disclosures, just to point out that in the past, myself and the team here have received royalties from the sales of the Gel Melbourne OA shoe in the past that I'll be talking about a little bit later on in this presentation. So I probably don't need to spend much time on setting the scene for why knee osteoarthritis is a big problem, but we know this is data that you can see before you from the Global Burden of Disease study, and probably sort of the most up-to-date data on the burden of osteoarthritis from a global perspective. And it's quite a busy slide, and we see lots of graphs there, but really the message of the story here is that osteoarthritis really starts to take off and become a problem from about the age 40 and onwards, and so that's where you can see that really quite sharp upward trend in the graphs there. And if we look at all of this data together, we see a global prevalence of knee OA of about 3.8%. But obviously in certain age brackets and certainly across different countries, we can see those prevalence rates do vary somewhat. But this data tells us that OA and certainly also hip osteoarthritis, which I'm not talking about tonight, do impose a really major global burden of disease. And in fact, hip and knee osteoarthritis are ranked as the 11th highest contributor to global disability out of a total of 291 different health conditions in the 2010 Global Burden of Disease study. And I think that's a fact that we often don't really consider in a condition such as OA that we often think is somewhat benign. It's not a big ticket item where we hear about, you know, where there's high mortality. So I think it's quite significant to see how highly it ranks in terms of global disability. And because of that, or related to that, the health costs that osteoarthritis imposes in Australia and indeed worldwide are really significant. And data estimated that OA cost Australia almost $4 billion in 2012. And given the rising obesity rates that we're seeing and the ageing of the population, the modelling and estimations going forward for how osteoarthritis is going to impact society is only going to dramatically increase. So we've got a really big problem with managing patients with knee OA now, and it's only going to become a bigger problem in the future. I want to talk a little bit about the biomechanical rationale behind why footwear might have a role to play in the management of this condition. And particularly because we think of footwear as an intervention obviously applied at the foot, and we're talking about a problem that's at a joint more proximal, namely the knee, with knee osteoarthritis. And so if we have a little bit of a look or a think about the way normal gait biomechanics, what we know is that the load through the knee is applied somewhat disproportionately through the medial tibiofemoral compartment relative to the lateral compartment. And that's just by virtue of the way normal human walking happens and normal biomechanics. So what this slide that you see here in front of you is what we see with typical compressive loads in a normal healthy knee, so not even a knee with osteoarthritis. And it's probably because of this imbalance in load across the medial and lateral tibiofemoral compartments that we see that medial compartment disease is the most common radiographic pattern of osteoarthritis we see. So we see medial OA occurring far more commonly compared to lateral compartment disease. And the reason that we see this relative imbalance in load distribution across the medial and lateral compartments is because of the way the ground reaction force is positioned relative to the knee joint centre during normal walking. And that's what this slide is a bit of a simplistic attempt to show you that in a diagram. So we see that as we take a step on the weight-bearing leg, the ground reaction force that comes up through the foot runs medially to the knee joint centre, which creates a lever arm around the knee and therefore a knee adduction moment, which tends to put or increase the loading on that medial compartment of the knee. And this knee adduction moment is really important in the context of knee osteoarthritis, and indeed for a lot of what I'm going to talk about in this talk, but it's also relevant to lots of other biomechanical interventions that we typically advocate for knee OA, because many of those interventions are aimed at reducing this knee adduction moment in an effort to reduce some of the peaks that you see here on the graph to the right. So what this graph to the right shows you is a typical sort of trace that we would get from 3D gait analysis in our gait laboratory, one that we have here at Melbourne Uni, and certainly there's lots of those around the world where this sort of research is conducted. And what we see with the knee adduction moment is we see two characteristic peaks occurring over stance phase, one usually in early stance and one in later stance. And typically the first peak is the highest. And we also see an area under the curve, which is termed the knee adduction moment impulse, or typically we'll often abbreviate this to the CAM, or the CAM impulse under the curve. And what that reflects is it gives a bit of an indication of because load is applied to the knee not just at the time point, but over at a specific time point, like what we can see with the peaks, but over the duration of the stance phase as well. And that's what the CAM impulse takes into account. So it takes into account both those peaks in load, but also the duration for which that load is applied to the joint itself. So this is a key parameter that we measure in not just osteoarthritis research, but in particular in the context of knee OA. And it's a particular biomechanical target for developing interventions and indeed evaluating interventions, and often seen as a target for trying to reduce the risk of disease progression over time as well. So why is this parameter so important? Well, we know that the CAM, and I guess the gold standard way of measuring load inside the knee joint is to do it directly. And the only way that you can do that directly is by inserting or surgically inserting an instrumented knee implant into the joint. And certainly there are cases of this around the world where you have to pick your research patient very carefully because they're going to be, it's obviously quite an expensive procedure, an implant to insert, and you want people who are going to participate and be willing to come back and be guinea pigs and tested to be part of the research. But that's what this diagram is showing here, where if we take data from the gold standard, which is an implanted knee implant that can directly measure load, and we compare that data to indirect data we measure from 3D gait analysis that I've just shown you on the slide before, what we can do is compare to see how valid these indirect biomechanical markers are. And that's what these slides are over onto the right, that show you that we see generally pretty good correlations between the knee adduction moment and actual forces measured from an instrumented knee plant inserted into the knee itself. So that gives us quite a lot of confidence in what we're measuring from 3D gait analysis is a fairly accurate reflection of the forces applied inside the joint. And because we've been able to apply 3D gait analysis on larger study numbers, which is obviously what we need for research, because instrumented implants are typically only ever done in one or two very small number of patients, so you can never get a study with numbers as large enough to actually test any hypotheses accurately. So using 3D gait analysis, there's been a lot of work showing that measures of increased knee load, basically using the knee adduction moment and the knee adduction moment impulse, are related to an increased prevalence of structural abnormalities in people with knee OA. And these are structural abnormalities in both bone and cartilage. So typically seen bone marrow lesions, but also cartilage defects and loss of cartilage thickness and volume. We've seen significant relationships between increases in knee load and the risk of structural progression over time. So what this tells us is that patients who have higher markers of increased knee load tend to be the ones who will worsen structurally over time. And recent evidence suggests that that will also lead to an increased risk of knee arthroplasty. So it's also a marker of future likelihood of needing a joint replacement. And some work also relating increases in knee load to the development of knee pain in people further down the track. So quite a bit of evidence supports basically the rationale for trying to reduce medial knee joint load in people with knee osteoarthritis. And that's why there's quite a lot of interest in biomechanical strategies, such as footwear, knee bracing, obviously walking sticks are another strategy. And in fact, you know, if we think about the surgical equivalent, that's a high tibial osteotomy that aims to realign and reduce that load bearing over the medial joint compartment. So let's turn our attention a little bit to footwear. And why do we need to worry about footwear? Well, we know from a number of research studies that actually wearing shoes compared to barefoot walking increases the load applied over your medial knee compartment by around about 7 to 8% in people with knee osteoarthritis. That data is from a study we conducted a number of years ago, but this has been replicated by other research groups around the world and is consistent. So we certainly, the message you would take from this is, well, if we want to reduce knee load to ultimately minimise the chances of disease progression and minimise symptoms, we should advise people to walk around barefoot. And obviously that, in an ideal world, that might be the case, but that's obviously neither practical nor safe for many patients. And so what this has encouraged is a whole lot of research in trying to understand, well, which footwear, if we've got to advise what shoes patients should wear, what are the shoes that minimise these increases in knee load, and perhaps, if possible, try and keep the loads as close to barefoot walking as possible. And that's so. And I guess one of the important points to point out here is to go back to that slide is when we look at the data, just looking at bringing people into the lab and saying bring your own shoes, and obviously everybody wears different shoes. These increases in knee load with footwear are quite variable, and although as I've got there, the average is around 8%, in fact it can be significantly higher depending on the type of shoes that people are wearing. And I'm going to come back to this point later on in the presentation when I start to talk about different footwear criteria and characteristics. So we have, in looking at this data, we see quite a bit of variability, which suggests that some footwear styles are less load increasing than others. And so that's really what a lot of our research and a lot of research around the world has been focused on. So what I'm going to move into talking about now is what the evidence tells us. And unfortunately for clinicians, where we're often interested in what's the impact on symptoms and the clinical state for patients, most of the research in this area has been biomechanical. So that means, when I say biomechanical, I mean typically smaller studies conducted in gate laboratories, often using somewhat artificial criteria that are very relevant to the research setting, but perhaps not as generalisable outside of the gate laboratory, and with a particular focus on biomechanical measurements, such as indicators of knee load, and in many cases, many of the studies don't include any clinical outcomes at all. So what we can get from these studies is a good understanding of the biomechanical effects of footwear, but it's a lot harder to glean if any of these biomechanical effects can translate into clinical outcomes, whether they be improvements in symptoms or indeed worsening of symptoms if someone was to wear footwear that perhaps has less than ideal biomechanical effects. And another one of these reasons, the reasons behind this is twofold. One is that if you want to incorporate biomechanical, these types of studies that require clinical outcomes are typically randomised controlled trials, which typically require large patient numbers. And they can be quite difficult to do. Doing biomechanical 3D gait analysis on a large scale is really time consuming, and because it's time consuming, it's actually quite costly from a research perspective. But also doing trials of footwear are inherently difficult because you need patients to adhere to the advice and what you actually want them to do, which is to wear the allocated footwear that you're providing them, usually over a fairly extensive time frame, and that can be quite problematic, getting patients to wear a single pair or one or two pairs of shoes and not their own. And one of the other limitations of the body of research is that most research has focused on a single specific model of shoe, that rather than a particular class of shoe or footwear characteristics, which makes it quite difficult to generalise findings from a single model of shoe over to a broader clinical environment, or indeed if that model of shoe gets taken off the market and doesn't even exist anymore, which is something that since I've been working in the footwear space, I've come to realise how frequently footwear retailers and manufacturers turn over their shoe models and certainly update them and relaunch them and rename them on a near annual basis. However, most of the work in this area has focused on two categories of shoe, and these ones are the ones I'm going to focus on tonight. So the development of novel unloading knee shoes developed specifically for people with OA, Or another group of shoes that I'm going to term, or not just myself, but they're termed in the literature, mobility or minimalist shoes. So I'm going to talk about the current evidence for both of these shoe classes. So if we turn our attention firstly to sort of novel unloading shoes, what I want to talk about is some footwear that we developed in conjunction with ASICS over a number of years based on our biomechanical research. And so what you see here in front of you is a shoe that's on the market now called the Gel Melbourne OA. To the eye, it looks like a normal sort of recreational shoe, so you really can't see the differences. But the unique design features about this shoe are what you see on the slide there. It contains a triple, oops, I don't know why that's just gone forward, sorry about that, a triple density midsole that is stiffer or more dense laterally compared to medially. So effectively, when you stand on that shoe sole, it compresses or squashes down medially and effectively acts as a lateral wedge, pushing the foot out into an everted position. And within the shoe itself, attached to the sock liner, is a mild 5-degree lateral wedge insole as well. So these shoe refinements have basically stemmed from another biomechanical intervention, which are lateral wedge insoles that you can insert into the patient's own shoes. But because there's a number of issues with that, we've done a lot of research into those wedged insoles where patients have difficulty stuffing these somewhat lengthy and oftentimes fat insoles into their own shoes, and it makes their shoe fit quite tight and uncomfortable. So you can get some adverse effects like blistering and rubbing. We thought rather than we took basically the design of the lateral wedge and incorporated it into the shoe itself to try and overcome some of these difficulties. And then conducted some research to ensure that our new shoe continued to have those same biomechanical effects that we know that lateral wedge insoles have. And certainly the evidence, this is data from our one of our studies that shows that this new novel unloading shoe that has been designed specifically to reduce the knee adduction moment does in fact reduce the knee adduction moment in our two target groups. So in this study, we wanted to take healthy controls who had no pain and no knee pathology compared to a group with symptomatic knee OA, that's the group you see at the top, and a group that we deemed at risk of OA, so overweight people but with currently no symptoms. So those were the two target groups, the top two graphs that we saw this shoe as having a role. And so what you can see here is that we observed an 8 to 9% mean reduction in the external knee adduction moment in these people with knee OA when wearing the shoe, and a similar level of reduction as well in the overweight and asymptomatic people. These graphs highlight the variability in these biomechanical effects, and this is certainly not unique to this shoe or indeed to any footwear. We see these types of variable biomechanical effects. Anyone who's familiar with orthotic literature will know that there's a highly individual and variable effect. And what we see here is that the vast majority of people got a reduction in the adduction moment, but a couple of people actually had an increase, and the magnitude of reduction can be significantly higher than this mean 8 to 9% reduction that we saw there. So leading on from this work that proved the biomechanical benefits of this footwear, we then looked at, well, how's it having its effects? And this is just it's a bit of a complex slide, but it just shows the biomechanical mechanisms for how this shoe works, where you can see that basically when people wear the osteoarthritis shoe, if we look at the diagram on the left, we see the shoe causes a reduction in the frontal plane ground reaction force magnitude, as well as a change in the lever arm, a reduction in the lever arm around the knee joint, which altogether help to reduce that knee adduction moment. Interestingly, in the overweight patients, we also saw another adaptation which occurred proximally up at the trunk, where it also encouraged them to lean a little bit more laterally, which is a known gait compensation for helping to reduce medial knee joint loading. So certainly a slightly different mechanism there in patients who don't have knee pain, but all achieving the same biomechanical benefit of a reduction in load about the medial compartment of the knee. So on the back of this research, which we did through a linkage grant on which ASICs were partners, ASICs went ahead and commercialised the shoe and released it onto the market a number of years ago. And you can see it here where it retails for roughly around $180 through a range of footwear retailers. But we wanted to know, we still had more questions, and we wanted to know, can this shoe, we can see the biomechanical benefits, but does it translate into clinical benefits? And so that led us to conduct a randomised controlled trial, or the SHARK trial, as we called it, over a few years, that was funded by an NHMRC grant and was published last year in the Annals of Internal Medicine. So you can see the abstract there from that publication. And I'm going to talk a little bit about the design and the methods and the main findings from this study now. So as I said, it was a two-arm parallel randomised controlled trial that was prospectively registered, and we published the protocol in 2014 as well. So you can find a lot more information and background on in the introduction and methods in the protocol paper than what you can actually find in the main trial paper itself. It was funded by the NHMRC, and we recruited 164 people with symptomatic and radiographic knee OA from around the community in Melbourne. We had two primary outcomes measured at 6 months, and one of these was a pain outcome, which was measured on a numerical rating scale where patients were asked to rate their average pain on walking, as well as, and we had another co-primary of self-reported physical function measured on the WOMAC questionnaire, which many of you are probably familiar with. It's a patient-reported osteoarthritis-specific measurement tool. Participants in this study were blinded, and because all of our outcomes were participant rated, you can also consider our assessors blinded, so a double-blinded trial. This is what the shoes look like. In order to blind our participants, we selected another ASICS comparator shoe, or a conventional walking shoe that looked fairly similar to our osteoarthritis shoe. And our OA shoe you can see in the bottom image there. And the top shoe was a conventional walking shoe that didn't contain any of those specific design features of our OA shoe. And so you can see that visually the shoes were very similar, and patients weren't told which shoe they were allocated, nor were they told the specific design features of the OA shoe, because it does feel a little bit, it feels a little bit unusual when you wear it, and we didn't want to cue patients into what the shoes should or shouldn't feel like, so to maintain blinding. And I haven't got presented data here today, but we assessed the rigour of our blinding and proved at the end of the trial that we were successful in maintaining patient blinding. Patients were asked to wear the shoes every day for at least 4 hours for 6 months, and ideally to wear their allocated shoes for the entire time that they were up on their feet for that 6-month period, and to avoid changing shoes. And I'll be honest, coming into the trial, we were a little bit anxious about how we'd go in getting patients to adhere to this. I'm not convinced they're particularly attractive shoes myself, but and also we're a little worried about how we'd go over the summer months when people were asked to wear these for 6 months. Because we were worried about that, we measured adherence quite closely. We got patients once a month to complete a weekly logbook and record every day the number of hours they wore their shoes. So we would have a snapshot every month for 6 months. At months 2 and 5, we posted them some shoe-mounted pedometers that we asked them to attach to their trial shoes, so we could get an objective measure of how many steps were recorded in their trial shoes. And again, at the 6-month mark, in case we were lost any or patients didn't return any of this interim data, we also asked them to overall rate their adherence overall at the 6-month mark using a numerical rating scale. This is just it's quite a busy diagram. It just shows you the flow chart where patients were allocated to each of the arms. And probably the main point here is that we had a really amazing trial team worked really hard to collect as much complete data from all of our people, and this is quite an achievement to have 98% of our patients completing primary outcomes at 6 months. Surprisingly, and we were really pleased, adherence was excellent in this trial. People really liked both shoes that were allocated to them. So we'd ask them to wear the shoes for a minimum of 4 hours a day, and if you have a look down those columns here, you can see that in fact the mean shoe wear for each month far exceeded that and was up around the 7 to 8 hours a day. And this was reflected also in the number of steps people took in the pedometers wearing their trial shoes, so up around 6 to 6,500 steps, which is probably fairly indicative of what this population, and indeed we thought they were probably even a little more physically active than what we were expecting. So we were quite pleased with adherence. So that meant that we could be quite confident in what findings we got from this trial, that they weren't impacted by poor adherence in one arm over the other. What I'm showing you here are the main findings across the primary and secondary outcomes. And firstly, I'm highlighting here the within group changes. So what we see in that red box is that basically within the groups, both unloading shoes and conventional shoes resulted in significant improvements in walking pain and physical function. And those mean changes there are clinically meaningful and relevant amounts. So we would say clinically relevant improvements in pain and function in both groups. But in a clinical trial, we're interested in the difference in change between groups. And what we can see here is that there was no difference at all in the amount of improvement in pain and function according to which shoes people were allocated. So essentially, both shoes resulted in improvements in pain and function, and our novel unloading shoes didn't make these improvements any greater than what we could see with the conventional shoes that we picked. Adverse events, there were a few adverse events reported, which you can see there. Typically, these were some initial ankle and foot pain, primarily with the unloading shoes, but interestingly also with the conventional shoes too. That typically these were transient events that resolved over the first month or so and largely did not impact on why people stopped wearing the shoes over the trial. So if you look over to that right-hand table, you can see that there was a whole range of reasons why people stopped wearing the footwear. So why don't biomechanical benefits of unloading shoes translate to clinical benefits? Well, perhaps it's because knee-OA symptoms aren't as strongly linked to the biomechanics as we previously thought. Perhaps the reductions in knee load with our unloading shoes aren't big enough to shift symptoms, and perhaps we need to get 20% reductions in the knee adduction moment, for example. Is it because of the variable biomechanical response to footwear and that perhaps only some subgroups of patients benefited and that was washed out in our cohort as a whole? Or is it because causes of pain are actually multifactorial and only a small proportion of patients have biomechanically driven pain? We've looked at some of these questions in some unpublished post-hoc analyses where we've looked at the effective potential treatment moderators, and certainly there's some evidence in our data that radiographic disease severity does seem to influence outcome, where we can see here in this graph that in the patients with mild radiographic disease did actually much better with the conventional shoes. That's the grey bar you see there, compared to the unloading shoes. However, when patients had moderate to severe radiographic disease, that trend reversed and those patients did much better with the modified or unloading shoes rather than the conventional shoes. So there's some evidence here that indeed there is a subgroup that may benefit most from a biomechanical intervention such as this, and it may be those who have moderate to severe radiographic disease. And this may be because these guys typically have higher knee loads than those with mild radiographic disease to begin with. What does it mean for clinical practice? Well, perhaps we should be advising patients against these types of unloading footwear when they only have mild disease. And for others, for patients overall, we can be confident that either shoe style is actually effective for patients with more severe disease. However, there are trends there that the unloading shoes may be more effective and in addition offer the potential to slow structural disease progression because of their unloading effects. However, we haven't tested that at this point. And so future researchers should consider constraining perhaps or testing these types of biomechanical interventions in a more targeted subgroup, perhaps of people with moderate to severe osteoarthritis. And this picture is really just to point out that there are other novel unloading shoes on the market developed by other researchers, and this is some footwear developed by researchers at Stanford University in the US that has similar design features to our footwear and unloading effects as well. Now, turning to mobility or minimalist shoes, what are these? These are shoes that are flexible and lightweight. And they were first sort of received research attention a number of years ago, and what you see here is the prototype shoe, where hopefully you can see in that image the specialised grooves across the sole to allow for natural barefoot-like motion. So this is a shoe that's been designed to try and mimic barefoot walking. And certainly the biomechanical evidence from this type of footwear in small groups has shown that this type of shoe can also lead to an 8% reduction in the peak cam compared to patients' typical footwear that doesn't have these types of features. So the researchers, there's been no clinical trials conducted on this type of footwear, but these researchers have certainly proceeded forward in releasing this type of footwear onto the market through Dr. Comfort. You can see this here, and it's called their shoe's called the Flex OA. It looks quite a bit different, a bit nicer compared to the prototype shoe you see in that image. So clearly some marketing work's happened there. And certainly the sole has come a bit of a way too. We've got I don't think this shoe is as flexible as it was initially in the prototype, but this is how this shoe has been released onto the market, and certainly I think it is available for people to purchase it through Australia as well. The only trial looking at the effects of minimalist shoes has been conducted in Brazil in a small sample of women with symptomatic radiographic knee OA, and they looked at a primary outcome of pain at 6 months. A critical limitation of this study is that participants were not blinded, which means because the patient-reported outcomes were used, the assessors weren't blinded. They used this, sorry about the image, this is the best I've got. It's basically a Maleka shoe, which is a flat, flexible canvas shoe, was in the intervention arm. And the control, for patients who weren't randomised to this intervention arm, they were asked to continue wearing their own neutral tennis shoes, which is why they were unblinded. They knew if they were being given the Maleka shoe or being asked to continue wearing their own shoe. Nonetheless, this trial did observe significant reductions in pain and function with these minimalist shoes over 6 months, which led the authors to conclude that these types of minimalist footwear can relieve pain, improve function, reduce loading, and also some evidence of reducing analgesic use in this study. However, there are some significant limitations in this study. As I've said, patients were unblinded, and we've got plenty of good evidence that shows that when patients are unblinded, they will often overestimate treatment benefits by about 25% when they're using self-rated outcomes such as pain and function. So it does leave a bit of a question in our mind as to how much of the clinical benefits in this trial because of the true biomechanical effects of the shoe, or just because patients were unblinded and they knew they were being given a brand new pair of shoes. So perhaps raises opportunities for research, but in a way gives us more questions than answers. So over the recent year or so, we've been trying to work on, well, what are some shoe classification criteria? Because it's very hard to go and say to a patient, you must go and get those Maleka shoes that perhaps are only available in Brazil. What are the criteria that help separate flat, flexible shoes from stable, supportive shoes? And we've done some work around characterising these, and you can see it in the table here, where we have developed and validated these criteria in using biomechanical studies where we picked shoes and separated them on the basis of these criteria you see here, namely heel height or thickness, shoe pitch, whether there's arch support or motion control features present or absent, the sole flexibility based on the rigidity component of the footwear assessment tool, and the weight of the shoe itself. And we selected a range of shoes that fulfilled these criteria and then tested them in the lab to see that, well, if we pick shoes based on these criteria, can we reduce the knee adduction moment, or do our flat flexible shoes picked based on these criteria reduce parameters of knee loading compared to shoes picked on the basis of stable supportive criteria. And certainly our biomechanical data showed, validated these criteria and showed significant reductions or less of an increase in the knee adduction moment from barefoot when people wore flat flexible shoes according to those criteria relative to shoes that have been picked for more traditional and I guess more acceptable stable supportive criteria. So it provides some evidence that these types of criteria can discriminate. And we've just in the last week or two started recruiting for another large clinical trial that we're conducting to actually compare the clinical benefits of these two types of flat flexible shoes versus stable supportive shoes, where we choose a variety of shoes available in the market based on these criteria to see if there is a differential impact on knee symptoms over time. But you'll have to wait 2 or 3 years for the outcomes of that trial. So coming up to the last aspect of my talk, what should we be advising our patients? Well, there's lots of clinical guidelines out there that we can turn to as clinicians for guidance about what we should and shouldn't be doing in clinical practice. And this slide just highlights some of those that you may like to look up for your own benefit later. But certainly if we have a look at the clinical guidelines out of the UK, what we see is that the core treatments for people with OA include education, advice and information access. And you can see that shock absorbing shoes and insoles are featured in the outer ring, but I would argue that education about appropriate and inappropriate footwear is part of core treatment advice. Certainly if we have a look at the guidelines developed by the Osteoarthritis Research Society International, they don't drill down to specifics, but they advocate biomechanical interventions across the board for these 4 phenotypes. If you look into the different coloured boxes, you see that biomechanical interventions, of which footwear is one, is an advocated treatment for a range of different patient presentations for people with knee OA. So if we extract out of the clinical guidelines, what are the experts telling us that we should say? And unfortunately, we can see there's somewhat conflicting advice here. Advice from the UK says we should offer advice on appropriate footwear, and they, as part of core treatment. Unfortunately, there's no evidence to tell us what is appropriate footwear, so they decide, or expert consensus for their group was that appropriate footwear includes some shock absorbing properties. But in contrast to the European League Against Rheumatism, they also advise the use of appropriate and comfortable shoes recommended. And they've gone a little bit further with giving us, I guess, a little more concrete advice. No raised heel, thick shock absorbing soles are appropriate, support for the arches, and big enough and for comfortable toe space. The Aussie guidelines, as I've pointed out on the previous slide, recommend the use of biomechanical interventions directed by an appropriate specialist and don't go as far to say what we should or shouldn't be doing with footwear. And the American College of Rheumatology don't mention footwear at all in their guidelines. And the reason for all of this conflicting advice is because there are, certainly at the time that all of these guidelines were developed, very few or no clinical trials, and certainly very limited evidence about what impact any of this stuff, any shoes have on symptoms. So these guideline developers had to rely on expert opinion, and that often falls to the commonly held belief that we should support the arches and provide thick shock absorbing insoles. But if you'll recall my previous slide, those features actually contribute to the stable supportive shoes that actually increase knee joint loading. So it is a bit of a difficulty, and this is why some key research recommendations have been highlighted by these groups to help drive clinical practice in this area over the future. And so you'll see here in yellow that the UK has particularly highlighted which biomechanical interventions, including footwear, are most beneficial and which groups of patients do they have the greatest benefit. And similarly, EULAR has also highlighted the need for much more research into footwear to assess the effectiveness and also the costs of different types of footwear so we can better advise our patients. So where does that leave us at the moment in terms of what the evidence says? I think reasonable advice that clinicians should be giving patients are that there is no evidence, no clear evidence at the moment that any one particular shoe style is more effective than another for managing OA symptoms. I think comfortable, appropriately fitted shoes that allow natural foot motion should be encouraged. And there is certainly no evidence that suggests we need to limit overpronation in these patients in the absence of any foot or ankle complaints. And certainly we know that patients with knee OA do tend to be far more overpronated compared to age-matched peers without osteoarthritis. And we can't assume that that's an adverse consequence of the disease, but in fact it could reflect a compensatory mechanism that patients have adapted in an effort to reduce knee joint loads. So I think that's an important point. And irrespective of all else, we should be advising patients to avoid high-heeled shoes. The biomechanical evidence is very clear that even moderately heeled shoes increase knee joint loads. So flatter footwear styles should be advocated as much as possible in an effort to reduce these abnormal biomechanical parameters over the knee that have been linked to long-term disease progression. One other point I just wanted to highlight, I quite like some of these photos from of patients' own footwear that they brought in during the course of our shark trial. We wanted to know what were patients wearing, and I think for all of you out there who are clinicians, this probably isn't any surprise, but I would also be advising that patients regularly replace their footwear. If you look at the age, and certainly the age of some of the shoes reported to us by our patients, they were up to 15 years old. And certainly any shoe or any features of a shoe will not be acting in the way it was designed to at the time it was bought. You can see how worn down these soles are and how well worn shoes are. So I think that's another piece of advice that we need to be paying attention to. Just to finish off, I'd like to acknowledge the team here at CHESM and particularly the individuals you see on the slide there who have contributed and collaborated on all of this footwear research over the years, and also over to the right, some of the major sources of funding that have contributed to our research as well, and that includes ASICS, the ARC and the NHMRC as well. And I think at this point I'll toss it over to Jen to help us with any questions.
Thanks very much, Rana. That was just a very interesting and such a complex area, and interesting to see those international guidelines and the differences between them, and really the need for further research in this area. So it's great that you're have your specific interest on the issue of the footwear. We've got a couple of questions, and I certainly urge other people to think about things during the presentation and jot down their questions now, as we are about 7 minutes from finish time. One question is, what level of individual assessments have you done regarding foot structure and function, especially of the first ray and MTP joint with shoe selection?
Yep, that's a good question. We haven't drilled down to that level of detail. In our trials, we certainly look at taking baseline measures of foot posture and structure so that we can look at those as treatment effect modifiers in a clinical trial. And typically, we've been primarily looking at foot posture and not focusing as much on first ray and MTP joint, primarily because of the complexities and difficulties in measuring, in easily measuring parameters there in a reliable and valid method that can be used in a clinical trial and also be generalised over into clinical practice. So we've tended to focus on measures of foot posture, such as the foot posture index, which is a fairly robust and accepted measure of foot posture, but not specifically to what has been asked there.
Thanks, Rana. And a bit more of a comment, but it might be interested if you have a comment in reply. Flatter footwear styles can cause major loading over the mid-foot joint in people with moderate and forefoot equinus. We need to be careful to take this into account. Any comment?
Yeah. Look, and I think that is a good point, and it's certainly, you know, it's always a concern with intervening at a joint distant from the joint you're actually trying to treat, which is what we're doing here. We're applying footwear at the foot and ankle to try and fix the knee, and you've got to be careful that you don't rob Peter to pay Paul in that case. But in fact, and these are concerns, and there are risks of adverse effects, and the only way that we can test those robustly is through randomised controlled trials, which is exactly what we're doing now in our footstep trial that has just commenced, and we'll be robustly and carefully assessing the rate of adverse events. But this is a concern. I just want to comment that I think that sometimes it's a concern that turns out to be more of a concern in hindsight than it actually does in reality. So certainly there's always been a lot of anxiety about putting laterally wedged insoles, or indeed even if you look at our unloading shoes that serve to force the foot into eversion and therefore, you know, increase the eversion moment around the subtalar joint. There's often a lot of concern about what impact that might have on the foot and ankle. And although we see a little bit of an increased rate of adverse events in the early phases, we don't see anything long-term that's significant or substantial. And certainly in one of our trials, we followed patients out to 12 months with lateral wedges. But it is indeed a concern, and we and certainly also select our patients appropriately going into clinical trials, where we wouldn't pick patients with, you know, obvious with clear foot pathology. You know, I don't think they're appropriate for testing these types of footwear in.
And Rana, just a question with regards to your inclusion and exclusion criteria. I presume that's in relation to the SHARC trial.
Yeah, sure. They're quite extensive criteria, but broadly speaking, we typically run with clinical and radiographic criteria as developed by the American College of Rheumatology. So broadly, people aged over 50 with radiographic or X-ray evidence of osteophytes, knee pain on most days of the past month, and for our clinical trials we usually set a minimum of 4 out of 10 on a numerical rating scale, because we need to make sure we get people in who've got enough scope to reduce their pain at the end of the trial. It's no point getting in people who've got a pain score of 1 or 2 when we're actually aiming to get pain reductions of 2 or more. And certainly also with the SHARC trial and these footwear trials, we're focused more on medial compartment disease, so requirements where those radiographic changes are predominantly in the medial compartment, and anyone with a predominant lateral tibiofemoral compartment on X-ray is excluded from participation.
And just quickly, Rana, rocker style shoes.
Yep. That's a good question, and I did deliberately leave rocker style shoes out of this presentation in the interest of time, but it certainly is, and so rocker style shoes are those sort of, you know, MBT or Masai barefoot technology shoes that have a convex sole. We certainly have done research on rocker style shoes, and they certainly are often a popular shoe choice. We have shown that they also can reduce the knee adduction moment by different mechanisms, obviously from what we've shown in here. But we have, I guess, a few concerns about how suitable those types of shoes would be for more widespread recommendation for people with knee osteoarthritis, given their unstable sole. And we're talking about older people, often older people, with symptomatic knee OA, where we know balance impairments are a problem and they're at increased risk of falls. So we've had a student working on evaluating how these types of shoes impact balance and are just completing the analysis of that now. So I guess at this point in time, I wouldn't be advocating them until we've certainly got to look at the rest of our data. And there is no, there's been one clinical trial conducted a number of years ago using the Masai barefoot technology shoes, and that did not show any between group benefits on symptoms. So there's certainly no evidence to suggest they're more beneficial for knee OA symptoms than a flat-soled shoe. I hope that answered your question.
Great, thanks very much. All we've got a very quick question. Have you looked at all into the position of the foot relative to the tibia? Foot abduction, increasing load in the knee, question mark?
No, probably the short answer is no. That's not been something that we have looked at to date in our research.
We might have to actually finish there because we're right on 8 o'clock. Rana, thanks so much, and I think it might be worth getting you back into in the future just to sort of hear how things are progressing in this area of research, because it's obviously, you know, an area of great need and interest. So we might have to do that some time down the track with regards to yours and other international research. So Rana, thanks again for a very comprehensive and interesting presentation tonight, and thanks everyone for joining the webinar this evening. Can I remind you, please, about the next webinar we have coming up at the end of September, Thursday, the 21st of September, which will be on fatigue management for people with persistent pain by Fiona Thomas from the Alfred Health's Pain Clinic. So on that note, thank you everyone for joining this evening, and good night.